So with that, we'll move on to the next topic, that is Rituximab in ANCA, vasculitis and glomerular diseases. Basically, once we have added this Rituximab in the armamentarium of management of all glomerular diseases, it has found its own place even in the management of ANCA vasculitis as an induction as well as the maintenance. So let us listen to Dr. Jithu Kumar from Kerala. So what he has to say about the role of Rituximab in ANCA vasculitis. Over to you, Jithu.
One announcement with the permission of the chair, please. The PG quiz will start at 3 o'clock at Ruby Hall. The PGs who are interested, please assemble at the hall at 2:55 p.m. Thank you.
Thank you, ma'am. Good evening, everyone. And I thank the organizers of this wonderful meet for giving me this opportunity to stand in front of this august audience, presenting before you in 12 minutes Rituximab in ANCA glomerulonephritis. So this will be the outline of my presentation. What is the evidence of B cells being active in ANCA vasculitis? A brief about Rituximab and its trials in induction and maintenance. Where does Rituximab stand with respect to the guidelines? And what are the dose of Rituximab we use, and when to choose Rituximab over the conventional therapy what we use now? So as we've already heard from the previous speakers that the ANCA antibodies are very crucial with respect to the pathogenesis of ANCA vasculitis. And when it comes to where does this antibody come from, it's mainly from the B cells as well as the plasma cells. So it tells that the B cells are very important. And there are also certain autoreactive B cells which are present in the granulomas or the follicle-like areas of the granulomas. And these B cells have specific affinity towards the ANCA antigen. And also there are levels of BAF or the B cell activating factor which actually correlates with the activity of the disease. And so now we know the B cells are important. What do we have in our armamentarium against these B cells? So everybody knows it's Rituximab. Rituximab is a chimeric monoclonal antibody. It's chimeric because it has a murine component and also human component. And it acts against the CD20. This is how the CD20 looks like. The CD20 has two extracellular loops, and this different color represents the area at which different monoclonal antibodies directed towards CD20 act upon. The CD20 receptor is seen between the pre-B cell to the memory B cells of the B cell lineage. The plasmablast and the plasma cell doesn't have the CD20 and are out of the preview of Rituximab. We use the CD19 cell count to find out the efficacy of Rituximab and we maintain the CD19 count somewhere around 0 cells per cubic millimeter, and the CD19 receptor is found also in the pro-B cell and the plasmablast. Now how does the Rituximab act? It has different methods of action. The first one is a complement mediated. It activates the complement and introduces a membrane attack complex on the B cell. The second is a direct lysis. So the Rituximab with the complement attaches to the complement receptor on the natural killer cell, and the natural killer cell attacks the B cell and damages it. The third is by phagocytosis. The Fc gamma receptor on the macrophage gets activated by the complement bound Rituximab and cause the phagocytosis of the B cells. Now we all know that the face of ANCA vasculitis treatment was changed with the introduction of cyclophosphamide. But that was not enough for the scientific community. They went on searching for another drug which could be probably as efficacious as cyclophosphamide with lesser side effects. And that was the search for another drug, and that came into Rituximab. So the trials in Rituximab has to be divided into trials with respect to induction and trials with respect to maintenance. There are two trials in the induction. One is the Rituvas trial and the second is the RAVE trial. The Rituvas trial, I'd seen the screen, they tried to combine Rituximab with cyclophosphamide and they tried to compare it with cyclophosphamide. In the RAVE trial, they tried to compare Rituximab versus oral cyclophosphamide. And in both the trials, the cyclophosphamide limb received maintenance therapy with azathioprine, whereas the Rituximab limb never got the maintenance therapy. It's also important to note that both the limbs of both the trials, all of them got methylprednisolone with steroid taper. We'll be coming to the visual abstract of the Rituvas trial. It's very important that the Rituvas trial was trying to prove that Rituximab is superior to the conventional cyclophosphamide. So the cohort was newly diagnosed ANCA vasculitis with renal involvement. the number of patients were less, around 44 as compared to the RAVE trial, which had almost close to 197 patients. The first arm had rituximab at a dose of 375 milligram per meter squared every weekly for 4 weeks, and it was combined with cyclophosphamide at a dose of 15 milligram per kilogram on day 0 and day 15, that is 2 doses. The second arm had cyclophosphamide at a dose of 15 milligram per kilogram, and they were given for 10 doses. So the end point was a BVAS score of 0 at the end of 6 weeks. They also tried to see what are the rate of adverse events, cancer, and the death. And what was interesting is that they found out the remission rates were not very different between this arm and the second arm, and neither was the serious adverse events. That brought to the conclusion that rituximab based regimen was not superior to the standard cyclophosphamide regimen, and there was no reduction of the serious adverse events. Now coming to the RAVE trial, which is a little different, it's a double-blinded, double-dummy, randomized control trial. They had both new as well as relapsing ANCA vasculitis. The total number of patients were around 197. The BVAS score was 3, and they classified patients into both GPA as well as MPA based on the disease morphology and also based on the serology into PR3 and MPO. The endpoints here is a little more stricter than the rituximab trial. Here they required a BVAS score of 0 with a steroid stop at the end of 6 months. And what they found was there was not much of difference at the end of 12 months with respect to remission rates. But what was interesting is that in case of relapsing disease, rituximab fared better. So in relapsing disease, rituximab was better than cyclophosphamide. At the end of 18 months, there was not much difference between the two with respect to remission, relapse, and adverse events. And it concluded that rituximab was not inferior to cyclophosphamide in remission induction, but it was superior to cyclophosphamide with respect to remission. Now coming to the trials in maintenance, it's all confusing, but let's make it simpler. One is the main Ritsen trial, which is the main trial. Then we have main Ritsen 2 and 3. The main Ritsen 1 trial tried to compare between rituximab versus the conventional azathioprine. Whereas the main Ritsen 2 and main Ritsen 3, these are done on the same cohort over a period of time as a continuum. And then we have the third trial called the Rituximab trial. The main Ritsen trial, we compared rituximab versus azathioprine in a cohort. They had new disease as well as relapsing disease. The total number of patients were 115. The most important point, this cohort had predominantly PR3 positive disease, and they were all remitted with cyclophosphamide. The dosage of rituximab is important because we'll come to this again in the guidelines. The rituximab was dosed at 0 day, 14th day, 6, 12, and 18 months. And this was compared with azathioprine at a dose of 2 milligram per kilogram, and the endpoints were a major relapse at 28 months. And what they saw was the relapse rates in azathioprine as a maintenance therapy was higher, bringing it to the conclusion that rituximab is superior to azathioprine in relapse prevention in ANCA vasculitis. Now coming to the main Ritsen 2. The main Ritsen 2, what they try to find out is that as opposed to the conventional fixed dose of rituximab we saw now, they tried to see whether the second dose of rituximab could be given based on the ANCA titers and also on the CD19. So only if the ANCA titers went up, they dose for the second time, or only if the CD19 went up, they dose the second. So these patients were both new and relapsing. There were 162 patients, GP and MPA. They were in remission. And the outcomes, they found out that there was not much difference between the two. And in fact, the tailored people got less of infusions of rituximab. So the conclusion was the tailored rituximab infusion has equal relapse rates with an advantage of reducing the infusion. But the catch here is that those patients who relapsed also, many of them had a CD19 0 and no rise in ANCA titers. So whether they were actually tracing the right target is the question here. Now this is the schema of main Ritsen 2 to 3. This is what we saw as main Ritsen 2. And at the 18 months, at the 28 months, what they tried to do is that all those patients of main Ritsen 2 who were in remission were randomized to again another 18 months of every 6 monthly rituximab. And the other control arm never received anything. That is main Ritsen 3. So this had 97 patients with rituximab induction, and the Patients who got another 18 months of rituximab received it every 6 monthly, and it was compared with placebo. And they found that the relapse-free survival was 100%, and there was no difference in adverse events, coming to the conclusion that prolonging rituximab after the maintenance for another 18 months every 6 monthly reduced the chance of relapse. The Rituximab trial is another trial which was done predominantly in relapsing ANCA vasculitis, 85 patients, and the dosage of rituximab was different. They used 1000 milligram once in 4 months, 5 doses, compared with azathioprine, and they found out the relapse rates are higher in the azathioprine group as compared to rituximab with very similar adverse events. Now, where does rituximab stand with respect to the guidelines? So these are the KDIGO 2021 glomerular management guidelines, and with respect to induction, rituximab is kept at par with cyclophosphamide, so that it gives freedom to the clinician to choose between the two. But there are some clinical indications which they say rituximab would fare better than cyclophosphamide. So with maintenance, again, in maintenance also, the rituximab is kept at par with azathioprine in our KDIGO 2021 guidelines, but with a rider that in rituximab you can actually taper and stop the glucocorticoids, but not for azathioprine when you have to continue glucocorticoids. So in relapsing disease, it is recommended to reinduce with rituximab. In refractory disease, switch to alternate therapy. So if you're given rituximab, give cyclophosphamide for the second, and if you're given cyclophosphamide, give rituximab. But the ACR guidelines actually prioritize what to give first. This is the ACR 2021 guidelines, which says that in case of an ANCA vasculitis, the first choice is rituximab over cyclophosphamide. And once remission is attained, again they prioritize. They say that rituximab should be chosen above azathioprine. Now the dosage is simple. We already know it from the trials we saw. The induction is rituximab, 375 milligram per meter squared, once in a week for 4 weeks. It could also be given as 1000 milligram, 0 and 2 weeks. The maintenance dose is very similar to the trials we saw, 500 milligram at 0, 14 days, 6, 12 and 18 months. And in the maintenance therapy, if you're using 1000 milligram, it could be once in 4 months, 5 doses. So what are the special scenarios which you will be careful about choosing? Rituximab could be chosen over cyclophosphamide in children, frail elderly. In a premenopausal woman, we already know the ovarian reserve is poor and we don't want to lose it. And such patients, in patients who we want to steroid, avoidance of steroids, and more importantly, if you see a PR3 positive disease, relapsing disease, choose Ritux over cyclophosphamide. When it comes to maintenance therapy, relapsing and PR3 ANCA, choose Ritux over azathioprine, and obviously allergy to azathioprine, you need to choose it. So adverse events, you have to be careful about the infusion reactions, arrhythmias, infections, hypogammaglobulinemia, and PML. So let me conclude, my dear audience. Rituximab is an important role in ANCA vasculitis. It's superior to cyclophosphamide in relapsing and PR3 ANCA disease. It's definitely superior to azathioprine with respect to maintenance, and it can be used for steroid avoidance in protocol in maintenance. There are special situations when you prefer rituximab over cyclophosphamide, and always keep in mind the side effects of the drug. And thank you so much for patient listening. I'm grateful to in my institutes, SGPG and St. John's, to train me the way I am. Thank you so much.
Thank you, Jithu, for that excellent coverage on various trial and the guidelines. You can please join me.